Everybody, welcome back to UWorld's Next Gen NCLEX review session. My name is Jackie and I'm a nurse here at UWorld. We're so glad to have you guys here with us today. We are going to be talking about peptic ulcer disease. So we have an agenda pulled up for you guys for what you can expect, but we're going to walk through the patho, clinical features, diagnosis, interventions, medications, and then we have 3 practice questions we're going to do at the end. One of these is going to be a next gen type item. So we're going to talk about a little bit about acute upper GI bleeds and lower GI bleeds. So stay tuned to the end. The sessions run anywhere between 20 and 30 minutes. So we hope you'll stick with us for those questions. But as always, we encourage you guys to follow us at UWorld Nursing on your favorite channel for more information about our live sessions. Make sure that if you're on TikTok, you guys share this session and follow us. We have a lot of great information. We want to reach as many of you as possible. These sessions are always available on demand on Facebook and YouTube afterwards, so you can always go back, get a refresher, review any information you need to review again. So as always, ask questions. We have our content moderators moderating the chat today. They're there to help you, so we'll try and answer as many questions as possible. And one of our favorite things that we've been able to kind of do, especially this summer with these live sessions, is celebrate all of you guys that have passed your NCLEX. So if you guys came back to let us know you passed, make sure you drop that comment in the chat. We want to celebrate you guys. And if you do any big reveal videos like on social media, make sure you tag UWorld Nursing. We'd love to celebrate you on social media as well. So if you haven't tested, let us know your date. We're thinking of you. We have a ton of great information to help get you prepared. So, all right, with that being said, let's see. Oh, and congratulations. I'm seeing some people testing tomorrow that have already taken their test. You guys are going to do great. So, well done and good luck. Okay, so we are going to pull up an image to kind of get us started today. So again, we're talking peptic ulcer disease. We have 3 questions we're going to do at the end, but we're going to kind of start at the beginning. We're going to walk through the pathophysiology of peptic ulcer disease, and more so just kind of starting at the beginning with our GI system. So when we talk about our GI system, think about everything related to food, all the way from the beginning of chewing food all the way down to digesting food. So our upper GI tract is going to include like our mouth, esophagus, stomach, and duodenum, which is the very first part of our small intestine. And then our lower GI tract is going to be everything after that. So think about our large intestine, colon, rectum, and anus. So the word peptic is really derived from the word pepsin, which is the primary digestive enzyme in our stomach that breaks down protein. So you can kind of picture that in your head. We have an enzyme that's like almost attacking our stomach contents, but this enzyme, it's not going to work alone. So there's also stomach acid that kind of works the same. It's going to break down our stomach contents so it can go from kind of chewed food sitting in our stomach to making its way into our small intestine. So peptic ulcers happen when these enzymes and that stomach acid go overboard, and instead of just breaking down the food and protein in our body, they start to break down that like protective layer in our stomach, so that mucosal lining. So this erosion, it's typically going to happen in the stomach or in the duodenum, again, which is that very beginning of our small intestine, and that mucosal layer, it's going to get kind of worn down, and that can lead to ulcers. And why this is so important for us to know, a lot of people have peptic ulcer disease, have stomach ulcers, but if they're left untreated, why it's so bad is it can lead to bleeding and even perforation. And when we think of perforation of our stomach or our intestines, we think about all that bacteria, anything that can make us really sick, kind of escaping one cavity and leading into another. So we worry about peritonitis and sepsis, septic shock. So that's really where the life-threatening kind of portion of peptic ulcer disease comes in, is when these ulcers get so bad that they start bleeding, and then that we worry about perforation and kind of subsequent sepsis, peritonitis, all of that. So again, that's kind of the big picture of what's happening with peptic ulcer disease. I kind of will describe this a little bit later, but how you can kind of picture those ulcers is like when, you're younger and you're riding a bike and you fall and skin your knee. Those ulcers are like a skinned knee in our stomach. So everything is exposed. When it's exposed to that stomach acid, it's going to hurt a lot, cause a lot of pain and discomfort. And so that's kind of how you can maybe picture what's going on with this a little bit. Okay. But let's use the chat. Let's warm up the chat. Let's see what you guys know about peptic ulcer disease. So I want you guys to tell me, what are some risk factors for peptic ulcer disease? So again, let us know, what do you know about risk factors for peptic ulcer disease? And I'm going to skim through this chat and say as many congratulations as I can, because I see a lot of people that passed their NCLEX and passed using UWorld. So that's amazing, you guys. We're so glad. That's why we're here doing what we do. So we're so happy to know that. And good luck to everybody who's taking their test. I see someone's taking it tomorrow. Best of luck, and July 8th. So good job, you guys. All right. Okay. Let's see. Okay, so we are looking for risk factors for peptic ulcer disease. And, I'm seeing sepsis. That's definitely a big complication. Awesome. Okay, so let's talk about some risk factors. So in general, risk factors are going to be things that contribute to the injury of that mucosal lining in our stomach and duodenum. So most commonly is going to be an H. pylori infection, or a Helicobacter pylori. So this is one of the biggest contributing factors to peptic ulcer disease. Other medications can contribute to this. So this is going to be things like NSAIDs and corticosteroids. And we have a little table that I will pull up, or if it's not up already, you guys can see. But again, it's a quick snapshot of a lot of this information. Not fully encompassing, but enough to hopefully get the wheels turning and kind of remind you of some of what you need to know about peptic ulcer disease. All right, so we have H. pylori bacteria. We have medications like NSAIDs and steroids. We have GI irritants. So think of anything that's going to hurt the stomach. So smoking, alcohol consumption, caffeine, things like that. Even stress. I'm sure you guys in nursing school, I'm sure somebody on here maybe has a stress ulcer from everything that happens in nursing school and getting ready for your NCLEX. So again, pretty straightforward. Bacteria, meds, irritants, stress. Those are the big kind of risk factors, contributing factors to peptic ulcer disease and these stomach ulcers. Okay, so we're going to use the chat again and check in about manifestations. So what does peptic ulcer disease look like? So what are our clients going to complain of? I'm going to give you one manifestation to start with. That's going to be pain. So besides pain, what else are these clients going to have? So let us know what you guys think. All right. Good job, everyone. All right. Let's see. I'm seeing a lot of good answers come in. Good job, you guys. Good work, everyone. All right. So clinical features, just to walk through some of this with you guys. So we already kind of talked about pain. So pain, it's more than just generalized pain. This pain is going to depend on where the ulcer is in our stomach. But a lot of times clients with peptic ulcer disease, they're going to complain about left or mid epigastric pain. So really in that stomach region. So beyond that, let's talk about the timing of pain. So pain is typically going to be worse after eating. So if you have a gastric ulcer, meaning the ulcer is in the stomach, the pain is typically going to peak around 1 to 2 hours after a meal. So this is because when we experience this is when we're going to experience that peak production of stomach acids and enzymes. So this is when our food is going to be broken down mostly. So that acid is going to irritate that ulcer and cause that pain. So again, think about skinning your knee and cleaning it with alcohol. That is going to hurt a lot. So same principle, when we eat and our stomach has to break down that food, that acid sitting on those ulcers, that's what's going to cause that pain. So it's going to be worse in our gastric ulcers. So when they're in our stomach 1 to 2 hours after we eat. But same idea, if we have a duodenal ulcer, that time's going to be a little extended. So think 2 to 5 hours. So that food in our stomach has to make its way kind of through the stomach into the small intestine. So pain is really going to peak around 2 to 5 hours for clients with a duodenal ulcer. All right, so let's think, the other thing to know about pain, it's typically going to be relieved with antacids. So what antacids do is they neutralize that acid in our stomach. They don't do anything, or they don't work how other medications do about the production, like decreasing the production of acid, but what they do is neutralize existing acids. So if pain is relieved with antacids, a lot of times we can kind of correlate that to a peptic ulcer disease diagnosis. Okay, so some of our other manifestations of peptic ulcer disease, these are all going to be related to complications associated with peptic ulcer disease. So we talked about bleeding and then perforation. So when we're talking about bleeding, what this can look like in clients is melena, which is dark stool or blood that has passed through like the entirety of the GI system, essentially starting in our stomach. So that's how we're going to see that dark, really dark stool. We can also see hematemesis, which is essentially throwing up blood. So seeing that bright blood or even coffee ground blood, again, it's all dependent on where the bleeding happens and how it interacts with that stomach acid. That's what's going to kind of indicate that color. And then the other big complication, perforation. So as that ulcer kind of wears down to the lining of the stomach, it can eventually cause a tear. And again, we worry about that tear because those stomach contents are going to escape into like the sterile cavity that's our peritoneal cavity, and that can cause peritonitis, which we know can lead to sepsis and septic shock, and that's the life-threatening part of peptic ulcer disease. So I want to ask you guys, what do you think peritonitis looks like? Like, what is that big hallmark manifestation of peritonitis? Let's see, what do we see in the chat? Let's see. All right, let's see. Oh, I see a question in here about the pain. So pain is worse, like pain can be kind of variable, but when it's the worst is when that stomach acid is being produced. So again, for stomach ulcers, 1 to 2 hours after we eat. For duodenal ulcers, 2 to 5 hours. And again, that's all about when pain is the worst. All right. Okay, I'm seeing some good answers come in. So when we are talking about peritonitis, again, some of those hallmark manifestations are going to be that rigid board-like abdomen, diffuse widespread abdominal pain, and guarding, meaning they don't want to be touched. Everything hurts when they move. So, but really that rigid board-like abdomen, that's a big indicator that we have kind of contents in our peritoneal cavity that should not be there. So good job. I saw a lot of good answers come through on that one. All right, we are jumping in. Let's talk about diagnosis. So we have covered patho. We've covered kind of our clinical features or manifestations of peptic ulcer disease. Let's talk about diagnosis. So I'm going to ask you guys another question. Okay, so will the healthcare provider perform an endoscopy or colonoscopy to diagnose peptic ulcer disease? So endoscopy or colonoscopy? Let us know in the chat what you guys think. Awesome. Good job. I'm seeing a lot of good answers come in. Thanks everybody on Instagram, a bunch coming in on Instagram. Again, it's not too late to share this if you're on TikTok. So thank you guys so much. All right. Okay, so we're going to pull up an image of an EGD. So again, since peptic ulcer disease is typically, or is the upper GI tract, we're going to perform an upper endoscopy or an EGD. So it's going to go through our mouth, down our esophagus, into our stomach, and into the duodenum. So it's going to visualize everything in that upper endoscopy. A colonoscopy is going to be more related to problems with our lower GI tract. So during the EGD, the healthcare provider can really visualize that mucosa. They can find the ulcers if that's a cause. They can cauterize any bleeding or stop the bleeding. And then they can biopsy that mucosa and test it for anything like H. pylori. So again, we need that endoscopy to really identify what's going on. Typically, these clients are going to present with pain. So we need to identify what's causing that pain. Is it an ulcer? Is it an infection? Do we have bleeding? Things like that. So that's what the answer answers. You guys did great. I saw a lot of people answer endoscopy, so good work, everybody. Okay, so we're going to bring back up our peptic ulcer disease table for you guys, and we're going to walk through now nursing interventions. So we're kind of in the home stretch of all of this for you guys. And again, stay tuned. We have 3 questions, and we're going to do an NGN type question. Okay, so when we're talking about nursing interventions for peptic ulcer disease, we are going, it's really how we care for these clients, how we treat them. It's all going to depend on if we have a bleeding ulcer or a non-bleeding ulcer. So for non-bleeding ulcers, if the cause is going to be an H. pylori infection, the client's going to need to be given antibiotics. So it's typically a regimen of clarithromycin and amoxicillin along with a proton pump inhibitor like pantoprazole, or what you might know it as Protonix. So we're going to kind of take a little detour and talk about proton pump inhibitors here for a minute. You are going to give these medications out to so many clients when you're in the hospital setting. So many people require proton pump inhibitors. So it's really important to know kind of what some of those adverse effects can be and what long-term use of PPIs can lead to. So we're going to kind of walk through some of that. So proton pump inhibitors reduce the amount of stomach acid the stomach produces. So again, we talked about how antacids neutralize stomach acid. Proton pump inhibitors kind of go a step before that, and they kind of like inhibit how much acid our stomach is producing. So because they change the pH of our stomach, so remember, things that are acidic are going to bring our pH levels down, like our number down. So some microorganisms can grow that typically wouldn't. So when you think of acid, I kind of feel like you can think of it as like bleach. It's going to kill germs and bacteria, anything that shouldn't be in our stomach. But when you kind of lower that pH in our stomach, some bacteria are going to be able to grow and thrive. So that's how we can have a risk for infections like C. diff or even pneumonia. So anything that can proliferate into our stomach and spread outside of our GI system. So again, with that being said, with Protonix, we're going to encourage like the lowest dose for the shortest amount of time. PPIs can also cause malabsorption of vitamins and minerals, especially if they're given for high doses or with long-term use. So what we're going to worry about is reduced calcium absorption, so we can kind of connect the dots on that to bone fractures or even osteoporosis. And then continuous PPI use, typically for like more than 2 years, can be associated with reduced vitamin B12. And we know B12 can be associated with anemia. So again, these are all things that kind of when you're putting puzzle pieces together, when you're caring for clients, things we need to know. And then magnesium absorption can also be reduced, leading to hypomagnesemia. So again, we talked about what magnesium kind of does with our body, and when we have magnesium on board, it's going to bring us down. So decreased magnesium is going to kind of make us a little bit more irritable, especially think about our neurosystem. Okay, and then lastly, with PPIs, most importantly probably, is we need to teach these clients how and when to take them. So we want these medications to work. So in order for them to kind of decrease that acid production, we need to have clients take them in advance of their meals. So at least 30 to 60 minutes before they eat is when we would encourage a client to take their PPI. Okay, so we kind of talked about PPI. We made our little detour. We're going to revert back to other medications that can be given to treat peptic ulcer disease. And one of those, again, something you'll commonly give in the hospital setting is sucralfate. So this is a medication that's going to bind with stomach acid. And with that stomach acid, it's going to form a really protective layer or mucosal, kind of like amp up that layer in the stomach. And it's going to help protect that ulcer. So again, it needs stomach acid to work, so it should be given either like 1 hour before meals or 2 hours after to ensure its effectiveness. So again, you have to kind of see how these medications interact and interfere with each other and give them appropriately so they can work and not kind of be like washed away with eating and drinking. Okay, so for bleeding ulcers, so we've kind of covered everything non-bleeding ulcers. We talked about like risk factor modification. We talked about PPIs and sucralfate. Now we're going to talk about what we will do for bleeding ulcers. So the first thing we want to do is put the client on NPO status, meaning nothing to eat or drink. So let's check back into the chat. Why is it important with a bleeding ulcer to put the client on NPO status? So connect these dots. Let's see what you guys think. All right. Oh, again, someone had a question about PPIs. Again, that stands for proton pump inhibitors, and kind of their mechanism of action is to reduce that acid production. All right. Okay, I'm seeing some good answers come in today. Thanks everyone on YouTube and Facebook. You guys are coming through with some great answers, so good job everyone. Okay. So when we're talking about peptic ulcer disease, we're talking about bleeding ulcers. NPO is important because when we are not putting food or anything into our body, our stomach is not going to be like keyed into making as much acid and producing as much enzymes. So again, when our client has a bleeding ulcer, we're going to worry about that bleeding progressing, and that can even progress to like perforation if that ulcer gets so bad. So that's going to cause further erosion. So if our client is NPO, then we're going to reduce that stomach acid production, and that's going to further worsen that mucosal erosion. So we're going to anticipate the client is also going to need an EGD. So we want to be sure things like consents are signed, the client has been NPO for the desired amount of time. And then again, when we're thinking bleeding ulcers, we're also going to monitor the client's H&H, or hematocrit and hemoglobin. So we're worried about hemorrhage. We're worried about needing to transfuse these clients. So we're going to want to monitor them for signs of like hypovolemic shock, low blood pressure, increased heart rate, signs of end organ damage, things like that. Okay, last part of nursing interventions is going to be client teaching. So we're going to stick to the basics. Again, we're going to teach these clients to avoid triggers. So risk factor modification is a big one. So avoid things like spicy foods, any substances that are going to stimulate acid secretion. So NSAIDs, alcohol, tobacco, caffeine, chocolate, anything like that that's going to get our stomach kind of in overdrive. And then we want to teach the client about signs of bleeding. So teaching them about changes in their stool color, or any like coffee ground emesis or blood if they throw up. And then also to monitor for signs of perforation, like that increased abdominal or back pain, fever, anything that can indicate a progression of ulcer to perforation to peritonitis to sepsis. All those dominoes those are the dominoes, and we don't want to kind of set off that cascade. So that's really what we have for peptic ulcer disease. You guys had some really great answers in the chat today, so thank you for participating. We are going to jump into our questions in just a second, but I wanted to bring up our schedule for you guys for this week. So tomorrow at 3 p.m. Central Time on TikTok and Instagram, we will be doing another question drill set. We're going to walk through skin questions, so kind of contagious skin conditions, rashes, all those kind of tricky things. So we're going to talk about that. And then we will be off on Thursday for the July 4th holiday. So again, you can find us tomorrow at 3 p.m. on TikTok and Instagram. All of our sessions are available on demand following on your favorite social media channels. So you're not missing join us live, of course, but you can always go back and refresh on anything you might have missed on demand. Okay. So that was our schedule. Let's jump into our first question. Again, we're going to do 3 questions today. So use that chat. We'll put your answer in the chat, and we will go from there. So I'll read the question, give y'all some time to answer, and then we'll walk through it. All right, so question 1 says, the nurse has taught a client with peptic ulcer disease who has a new prescription for omeprazole. Which of the following statements by the client would require follow-up? Option 1, I should limit my intake of foods that are high in calcium. Option 2, I can take the medication immediately before I eat breakfast. Option 3, I should take acetaminophen instead of ibuprofen if I am experiencing pain. Option 4, I I will notify my healthcare provider if I develop symptoms of a respiratory infection. All right, so I'll give you guys some time to answer, and then we will walk through it in just a second. All right. Very good, very good. Let's see what you guys think. I'll give you all about 15 more seconds and go from there. Very good. I'm looking at the chat here. You guys had a lot of good stuff on here. Good work, good work. Awesome. All right. Okay, so our correct answer is going to be option 1. I should limit my intake of foods that are high in calcium. So we talked about how over time, proton pump inhibitors like omeprazole can lead to a kind of decrease in essential vitamins and minerals in our body. And again, calcium is one of them. We have a risk of osteoporosis and even bone fractures. So when this question says requires follow-up, that means we're looking for a statement that's incorrect or it's not safe for the client. So that's what we see in option 1. We should encourage the client to increase their calcium intake, again, because over time their calcium can be depleted by the proton pump inhibitors. So that is an incorrect statement and one we would want to follow up with them on. So good work. Again, when we look at the other options, we can see taking the medication immediately before I eat. We need to take it at least 30 to 60 minutes to let it work. We don't want to encourage NSAIDs. Again, that's a risk factor for GI bleeds. Option 4, again, respiratory infections can mean that stomach acid has been, we kind of have like opportunistic infections happening because our stomach acid is not killing all the bacteria necessary. So good work, you guys. Okay. All right, question 2. The nurse is caring for a client who has gastroesophageal reflux disease and has been receiving long-term omeprazole therapy. The nurse should recognize that the client is at highest risk for developing option 1, jaw necrosis, option 2, vision changes, option 3, gait disturbance, option 4, C. diff infection. All right, let's see what you guys think. Awesome, awesome. Let's see what you guys see. Good work, everybody. Awesome answers coming in. Good job, everyone, on Instagram and TikTok. So good work, you guys. Awesome. All right, I'll give you all about 10 more seconds and we'll go from there. All right. Good job, good answers. Okay. All right, so the correct answer for this question is option 4, C. diff infection. So again, same idea as this question before. We can have these infections happen due to kind of the decrease in stomach acid being produced. So bacteria kind of have a better chance of surviving when our stomach acid is reduced. So we worry about a C. diff infection for clients on PPIs. All right. Okay, so last question for today. This is an NGN type question. So we're first going to pull up a scenario. We'll read it and then we'll move on to the question. So this is, again, something that is part of this next-gen NCLEX, something you'll see, something to expect. So UWorld has several practice questions that are case studies, NGN type items. So we hope you guys will check it out. All right, the nurse is caring for a 74-year-old client. They're in the emergency department, so let's read what the note says. It says, pain rated 8 on a scale of 0 to 10 in mid-epigastric area. 2 episodes of large black liquid stools in the morning. Veins surrounding the rectum are dark, bulging, and tortuous. Takes over-the-counter ibuprofen every 8 hours for right hip pain for the past 3 weeks. Daily medications include aspirin, carvedilol, lisinopril, and atorvastatin. History of right hip arthroplasty 5 years ago. Hypertension, hyperlipidemia, and H. pylori infection 1 year ago. Vital signs are pulse 110, blood pressure 90/62, respiratory rate 20, and SpO2 96% on room air. Okay, so I'm going to give you guys just a little bit of time to kind of look at that, read it through a little bit, because this on the NCLEX, you wouldn't lose your scenario, but for our purposes today, we're going to have the scenario and then bring up the question so you can visualize it a little bit better. So again, we have pain in the mid-epigastric area. We have some kind of odd stools. We have some kind of lower GI symptoms, pain, some NSAID use, H. pylori infection. So those are some of the main things to take away. So now we'll pull up part 2, which is the question. And this is a type of question that you guys will see. This is, again, a matrix type question. So you can kind of take these as you walk through them the same way you would any other question. They're just formatted differently. So again, it's asking you the same information, just in a different format. So, okay, so I will read it. For each finding below, click to specify if the finding is consistent with the disease process of acute lower GI bleed or acute upper GI bleed. For each finding may support more than one disease process. So again, this is a matrix multiple response, meaning that we can have 2 checkboxes in each row, but every row should have a checkbox. So that's why it says each column must have at least one response option selected. Okay, so I will give you guys a chance to answer, and you guys can just answer like, you can use numbers however you want to, but be creative in the chat. Let us know what you think. And I'll give you guys about 30 seconds to put your answers in the chat, and then we'll walk through a little bit more about upper GI bleed versus lower GI bleed. All right, let's see what you guys think. Good work, good work. Good job. Awesome answers coming in. Good work, everybody. Thanks again to everyone on Instagram for participating, and TikTok. So many of you guys are on today, so we appreciate y'all being here. All right. Okay. Awesome. Okay, so we will walk through this. So kind of thinking back to our scenario. So our client had dark liquid stools, 2 of them. So that's going to indicate that melena. We know that's going to be associated with an upper GI problems, peptic ulcer disease, bleeding ulcer in our stomach or duodenum. So for stool color, that's going to be associated with upper GI bleed. Rectal findings, what was being described, those are hemorrhoids. So again, hemorrhoids can be associated with a lower GI bleed. Think about where hemorrhoids manifest themselves. That's going to produce that bright red blood in stool. So that's what we're going to think of when we think about hemorrhoids. So far we have upper GI bleed is checked for stool color. Lower GI bleed is checked for rectal findings. Okay, medical history. So our client had an H. pylori infection. We know that is indicative of causing ulcers in our stomach, which can lead to those upper GI bleeds. So our medical history is going to be indicative of our upper GI bleed. And then over-the-counter medications, those are going to be our NSAIDs that we saw in there. So NSAIDs can definitely be a cause of gastric ulcers, upper GI bleed, all of those things. So good job. Hopefully you guys did great. Good work on all of that. So that concludes our session for today. We covered peptic ulcer disease. We ran through 3 questions, had lots of images, a table for you guys. As always, we encourage y'all to check out our free trial. Go to nursing.uworld.com. We have a great selection of questions, NGN type questions, case studies, standalones, everything you need to prepare for your NCLEX. We know you guys are kind of in the home stretch of testing for this summer, so if you haven't checked it out, we encourage you to do so. Come back tomorrow at 3 p.m. on TikTok and Instagram. We'll be doing a question drill, and then we'll be off on Thursday, so join us again Tuesday, noon Central Time, for our kind of content discussion. We're going to be talking about end-of-life care. So we appreciate y'all joining today. We look forward to seeing you tomorrow, and thanks again. Bye.